Lakshmi, we can start.
Yeah, ma'am. I hope students all join.
Almost, I have messaged Azra also.
Yeah. Yeah.
They'll be joining. We'll start, Lakshmi. If not, we'll be late.
Okay, ma'am. Sure.
Yeah.
Yes. Yeah.
Yes. Lakshmi, we can start.
Yes, ma'am. Yes.
I hope students all join. Almost,
Yes, ma'am.
Yes, we can.
Yeah.
Good evening, all of you. We will start the next second day session of the diabetes. Welcome, Dr. Chaithanya. So he will be, you can take over the session, sir.
Thank you, ma'am.
Yeah.
Are you ready with the slides?
Yeah. Yes, sir. I will. Hope it's visible.
Yes, yes. Thank you. Thank you very much.
Yes.
Yeah, fine. So good evening, all of you. Today, we're going to discuss mainly on the management of diabetes. And if time permits, we're going to touch upon the dietary aspects of diabetes. You will be knowing better than me when it comes to the dietary aspects. So I will not be concentrating much on the dietary part of diabetes management. Can we have the next slide? Next slide. So these are the various objectives of today's discussion. We are going to learn the various aspects of management of diabetes when it comes to medical management, management with diet, and management with lifestyle. Next slide. Next slide. Yeah, the basic challenge which we have, as we have discussed in the previous session as well, many of the patients having diabetes mellitus remain undiagnosed in India. Many of them are in the stage of pre-diabetes. So these are the various census that have been put forward. 47% of them are undiagnosed, and 70% of the patients discontinue the treatment because of various reasons. Let it be the cost, let it be the fear of the disease, let it be motivation, or let it be the side effects, whatever might be. So many of them don't continue the treatment for diabetes. They switch to native medicines like Ayurveda, homeopathy, Unani, or they will listen to some lecture over the Google or YouTube, and they'll start following diets like keto diet, and all these things will happen in India. And 55% of the diabetes patients, even though they are on treatment, they do not achieve their glycemic goals. So it always remains challenging when it comes to the treatment of diabetes. You need to motivate the patient. You need to make sure the patient is adherent to the therapy. You should explain the patient regarding the various good things, pros and cons of diabetes treatment. And you should tell them none of these drugs are harmful. None of the doctors sitting over there are going to prescribe a drug which is going to affect your kidney. Yes, definitely many of these drugs do their side effects. Not only the drugs used for the treatment of diabetes, any drug that is used in the treatment of any disease on earth will have side effects. So one question you can ask, let us say a patient is having cancer, and the doctor will tell you, if you don't take this treatment, you're going to die in 6 months. Will the patient say, no, I don't want to take this treatment. I will go for Ayurveda or homeopathy or Unani, or I'll follow keto diet? No, they will take the drugs irrespective of the side effects, irrespective of the cost. But when it comes to diabetes, they keep on asking us umpteen number of questions. Do we need to take this? Do we need to take that? And all those things. So it becomes imperative on our part to sit with the patient, to spend time with the patient, to counsel them. Before that, we need to have a sound knowledge regarding the various aspects of diabetes treatment and the various drugs that are being utilized and used in the treatment of diabetes mellitus. Lakshmiji, any issue with these slides?
1 second, sir. 1 second.
Not an issue. Take your own time.
There is some technical problem. 1 second.
You can stop and you can start sharing again.
Yes, sir.
Yeah.
Now it came?
Yeah, sure.
Yes.
So next slide. So you can broadly classify the diabetes management into 2 different parts: non-pharmacological, pharmacological. Non-pharmacological in the sense with the help of diet and lifestyle. That's where your role is very, very important. So always remember, there are 3 different pillars of diabetes management. If you visit any good doctor, I mean to say all the doctors are good over there, But a doctor who is more interested in the treatment of diabetes, they usually discuss these three pillars with each and every patient. One is diet, second is lifestyle, third is medication. Each and everything contributes equally. Let us say diet contributes 30%, lifestyle modification in the form of exercise or stress contributes to 30%, and medicines contribute to 30%. So ideally speaking, the role of any doctor in the treatment of diabetes mellitus is only 30%, one third. So two-thirds is being managed by the patient himself or herself. So we should always start with diet and lifestyle rather than start the other way around. Pharmacological is completely dealing with medicines. Next slide. So coming to the diet and lifestyle, it is aptly termed as medical nutrition therapy. So many of you know what is medical nutrition therapy. In medical nutrition therapy, we discuss the various aspects of diet and lifestyle. We take the dietary recall from each and every patient. We take the metabolic parameters into consideration. We check the weight of the patient. We check the height of the patient. We calculate the BMI. We give the target weight and target height. We have various formulae to calculate the ideal body weight. We use those formulae, and accordingly, we will give a target caloric intake for the patient. We discuss with the patient various aspects of diet, when to have, when not to have. To put it simple, basic thing which we tell the patients, we in the sense we doctors, we should ask them to eat on time. That is very, very important. Around 8:30 being breakfast, 10:30 in the morning, a big morning snack, 1:30 lunch, evening 4 o'clock snack, night 8 o'clock dinner, before going to bed. Why are these timings important? Many of the, not many, in each and every person on the earth, whether they're having diabetes or not, the insulin is produced during these timings. Insulin has a pulsatile secretory pattern inside our body, which has been established by various experiments like the clamp. So, what happens if a person is having diabetes? The insulin secretion will come down. Let us say you compare two different people. One person is not having diabetes, the other fellow is having diabetes. The one in whom there is no diabetes, let us say the insulin secretion is around 30 units. And the person who is having diabetes, the insulin secretion will be around 20 units. So the moment you start medication, the medicines will help in producing the extra 10 units of insulin, will make sure the entire 30 is working together. So if you have breakfast around 9:30 or 10, instead of having the breakfast at around 8:30 in the morning, then you have only 10 units with you. And where are you getting the 10 from? The medicines. So what is happening to the original 20? You're not able to utilize. So the basic reason behind eating on time is to make sure that you're utilizing the insulin that is present inside your body. This is of very, very, very paramount importance. Many of the patients don't eat on time. You should keep on telling them. First question they ask, I don't have hunger. I can't eat at 8:30 in the morning breakfast. It's too early for me. I will eat at only 10 o'clock. Yes, true. You will not have hunger. Tomorrow, if you want to eat breakfast at 8:30, you may not be having that appetite. But one day, 2 days, 3 days, 4 days, 10 days, 15 days, if you continue to eat at around 8:30, the body again starts modifying itself and automatically you will develop your appetite. During our childhood, when we were going to school, we used to have breakfast as early as 7:30, lunch by 12 p.m., dinner by 7 p.m., 8 p.m., finish off the homework, go to bed. Life was happy. Now everything has changed. We're sleeping late, we're getting up late, no exercise, keep on checking mobile for news, for messages. Even the mails also we're using the mobile, and everything has been digitalized. No proper food timings. That is the reason the number of diabetes patients is going up in India. This is basically a lifestyle problem. You should look at this problem like a disorder more than a disease. So you should always tell each and every person having diabetes to eat on time. The second thing is the quality of food. What you have is important. How much you have is not important. You give a diet chart, you tell them how much fat they should take, how much carbohydrate they should take, how much protein they should consume per day, and what about the oil consumption per day, and what about the various fibers that they need to include in the diet, various types of oil. All these things, if you discuss with the patient, then they will understand. And one more important, diabetes treatment, let it be the medicine, let it be the diet, is not generalized. It is personalized, it is precise. If you have a patient from interior Karnataka or North Karnataka, his lifestyle will be different from a person staying in Bangalore. When you look at a person from Punjab, his diet pattern is different from a person visiting from Chennai. So you should look at the geography. You should look at their various profiles, various things, various aspects. Then on you should suggest the diet pattern. And then comes the physical activity. Let them walk, let them do the regular walking. During COVID-19, they cannot go out and do aggressive walking or aggressive exercise in the form of gym. Wherever possible, whenever possible, they should start doing walking exercise. They should not sit idle for more than 30 minutes in a day. I mean, at any stretch, once in 30 minutes, they should get up, have a walk for 5 to 10 minutes and come back and sit. So morning walk is good, evening walk is good, and night when they finish their dinner by 8:30, let them wait for half an hour and walk inside the house for another half an hour. So these two aspects, the diet and lifestyle modification, will bring down the diabetes by 60%. And if a person is on the overweight or obese side, you should always advise them to target for weight loss. Next slide. So coming to the gist of the discussion, the pharmacological treatment. We have various agents that are used in the treatment of diabetes mellitus. To simply classify, we have oral agents, we have injectable agents like insulin, we have other agents which may or may not directly bring down the blood glucose value, but they are used in the treatment of other comorbid conditions like hypothyroidism, hypertension, increased bad cholesterol, and all those things. First, let us see regarding the various drugs that are used in the treatment of diabetes mellitus, which bring down the blood glucose levels. Next slide. So they're called is either as OHA, oral hypoglycemic agents, or OAD, oral anti-diabetic drugs. There is a small difference between OHA and OAD. You cannot say each and every drug. You cannot term each and every drug that is used for the treatment of diabetes. You cannot say it as OHA because few drugs like metformin, DPP-4 inhibitors will never cause hypoglycemia. They will just bring down the blood glucose values. But there are drugs like sulfonylureas, thiazolidinediones, which definitely cause hypoglycemia. So when you cannot use the term oral hypoglycemic agents in a general way. So to take care of that, we started using the term oral anti-diabetic agents. So all these drugs are called oral anti-diabetic agents. And again, these drugs are primarily used in the treatment of type 2 diabetes mellitus. They're not used in the treatment of type 1 diabetes mellitus. Hope you remember in the first session, we have discussed primarily there are 3 different types of diabetes, type 2, type 1, one that is seen during pregnancy. Even though we have identified more than 20 types, we confined our discussion only to these 3 types. So type 2, these different drugs are used. I'm talking about the oral agents. Type 1 exclusively use insulin. Pregnancy also, insulin is the only drug that is approved for the treatment of diabetes mellitus during pregnancy. Even though many of us use metformin off-label, it is not approved and it is not indicated. So these are the various classes of drugs. Starting with metformin, you can see right side panel, the name of the class, left side panel is the name of the drug. So I mean, left side is the name of the class. You can see biguanides, sulfonylureas, thiazolidinediones, alpha glucosidase inhibitors, DPP-4 inhibitors, glucagon-like peptide agonist, and sodium glucose transport inhibitors. To leave about these terms, don't get confused. We'll just simplify the discussion. So first, in the first session, we have discussed the pathophysiology of diabetes mellitus type 2. In type 2 diabetes mellitus, what is happening? The insulin secretion has come down, and whatever insulin that is present in the body is not acting on a proper way. What is the basic action of insulin? It will act on the liver. It will make sure liver is not producing extra glucose, either in the form of glycogenolysis or gluconeogenesis. The same insulin is going to act on the muscle. It will make sure the entire glucose that is present in the body is being utilized by the muscle and various other tissues of the body. So in type 2 diabetes mellitus, what is happening because of various reasons like lifestyle, stress, and irregular diet pattern, pancreas is not able to produce insulin in a proper way. Number 2, the liver and the muscle are being filled up with the fat so that the insulin is not acting properly on the liver or muscle. So we have to target these various pathophysiologies when it comes to the treatment of diabetes mellitus. For example, if you take metformin, metformin is the first drug that is used in the treatment of type 2 diabetes mellitus worldwide. It's been an age-old drug. we started using metformin way back in 1950s, 60s. So metformin goes and acts on the liver, and it will make sure that the liver and muscle are listening to the insulin. First thing, it will make sure liver is not producing any extra glucose. So it is going to block the hepatic glycogenolysis and gluconeogenesis. And the same metformin is going to act on the muscle. It will make sure the muscle is listening to the insulin. So it is called insulin sensitizer. The same way, you have the third class of drug by name thiazolidinedione. Example is pioglitazone. They are called PPAR gamma, peroxisome proliferator receptor activator gamma inhibitor. So these particular drugs also act like metformin. So pioglitazone acts on the liver, will make sure liver is not producing any extra glucose. And the same pioglitazone acts on the muscle and will make sure muscle is listening to the insulin. So metformin and pioglitazone are called insulin sensitizers. Then the next class of drugs, sulfonylureas. Sulfonylureas are called insulin secretagogues. They primarily act on the pancreas. They will make sure pancreas is producing more insulin. So they stimulate the beta cells of the pancreas to produce more and more insulin. That is the reason they are called insulin secretagogues. And then we have alpha glucosidase inhibitors. What are alpha glucosidase inhibitors? When we have regular food, let it be idli, dosa, vada, or rice, or biryani, whatever it might be, these food materials have complex carbohydrates. The complex carbohydrates will be broken down into disaccharides and monosaccharides in the gut. And from there, these particular disaccharides and monosaccharides are being absorbed. So there is an enzyme by name alpha glucosidase. This enzyme will break these polysaccharides into smaller molecules like disaccharides and oligosaccharides and monosaccharides. So when you give this particular medication, alpha glucosidase inhibitor, this medication is going to block this enzyme so that in spite of eating food, like let us say one idli, the idli is slowly digested. Immediately the sugar is not released. So the polysaccharides are slowly broken down into oligo, di, and monosaccharides. That is the reason these particular drugs act on the intestine, and these drugs should be taken with food, in between food, not before food or not after food. So when you eat idli, with the first bite of idli, you should take this alpha glucosidase inhibitor so that it goes along with the idli. It will make sure the idli is not releasing the sugar immediately. Metformin ideally is given after the food. Why? Because after the food, that is the time where liver is producing extra glucose. That is the time where you have glucose available in the body, which needs to be utilized by the muscle. So physiologically, if you give metformin after the food, it acts in a better way. Second important aspect, which we are going to discuss in the next few slides, is the side effect profile. Metformin ideally causes gastric problem, let it be burping, belching, flatus, and all those things. So that is the reason we advise the patient to have metformin after the food. Sulfonylureas are given before the food. Why? Because the moment the patient takes the food. Thiazolidinediones are also given before food, but you can give them after food as well. Alpha glucosidase inhibitors are given with food. Then we have the next class of drugs by name DPP-4 inhibitors. We can club these DPP-4 inhibitors and glucagon-like peptide GLP-1 agonist. Then we even had a discussion regarding the incretin therapy. What are incretins basically? When you give IV glucose and when you give oral glucose, when the patient is having oral glucose, there is more and more insulin production when compared with IV glucose. Why? Because the moment you eat food, there are two different types of cells in the intestine, K cells and L cells. These cells produce a special type of hormone by name GLP-1, glucagon-like peptide. When this particular hormone is present in the body, that will go and stimulate the beta cells of the pancreas to produce more insulin. It will stimulate the alpha cells of the pancreas to cut down on the glucagon secretion. It will even induce the satiety at the level of central nervous system. It will delay the gastric emptying. So it has many effects. But the problem with these hormones, these are called the incretin hormones or gut hormones, is that They're very, very short acting. Their action is only 2 to 3 minutes. Why? Because there is an enzyme by name dipeptidyl peptidase 4. This enzyme is going to cleave this hormone. So we started producing drugs which are going to block this enzyme. They are called the DPP4 inhibitors. We have various drugs like vildagliptin, sitagliptin, saxagliptin, linagliptin, teneligliptin, alogliptin. So many molecules are present in the market. And in the same way, not only did we produce a drug which is going to inhibit the enzyme, we were able to bioengineer and produce the GLP-1 molecule as well. So these molecules are called GLP-1 receptor agonists. They look like the GLP-1 molecule, but they are not the exact GLP-1 molecules. They act at the level of same receptor where the GLP-1 molecule acts. So we have exenatide, we have liraglutide, we have albiglutide, we have dulaglutide, we have lixisenatide, we have semaglutide. And many of them are injectable therapies, except for semaglutide, which is a oral tablet that's been manufactured in US. It got approved in the month of September last year. And in India, we're expecting the drug anytime. And lastly, we have sodium glucose co-transporter SGLT2 inhibitors. Likely, I told you in the last session, there is a backdoor in the kidney. Initially, kidney is going to excrete the entire glucose. But glucose being an essential molecule, the same kidney is going to reabsorb the entire glucose through a backdoor. The name of the backdoor is called sodium glucose co-transporter 2. And when you block this particular door, then kidney will not reabsorb the glucose. So we have drugs like empagliflozin, dapagliflozin, canagliflozin, which are these drugs which are going to block this drug. SGLT1 receptor is present in the intestine. Very simple thing. I don't know how many of you remember, we have this ORS, oral rehydration solution, which is especially given for diarrhea, especially in children. So in oral rehydration solution, if you look at the composition, it has salt as well as glucose. Do you know why the salt and glucose are combined together? Basically, what is happening in a diarrhea, they're losing fluids. Along with the fluids, they're losing salt. So you can directly give the salt. Why do you need to combine the glucose and salt together? Because there are some receptors in the body. They are called sodium glucose co-transporters. When you combine the glucose and sodium, glucose will take sodium along with it. Sodium will take glucose along with it. That is the reason in a oral rehydration solution, we have a combination of glucose and sodium. The same mechanism applies here. It is the same receptor, but instead of being in the kidney, intestine, it is present in the kidney. So when you give this particular drug, this drug is going to block this receptor. So glucose is not being reabsorbed. In the same way, sodium is also not reabsorbed. Look at the molecule's name, sodium glucose co-transporter 2 inhibitor. So it is inhibiting both glucose reabsorption as well as sodium reabsorption. So the patient will start excreting more and more glucose in the urine, more and more sodium in the urine. So not only the blood sugar will come down, the blood pressure will also come down. They are very, very good and promising drugs. But the problem with these drugs, you should drink plenty of water, because when there is more glucose in the genital tract, right from the kidney to the urethra, there is a chance of developing genital infections or urinary tract infections. That is the reason you should drink plenty of water, so that the extra glucose that is present in the urinary tract is being shunted out. So apart from these oral drugs, we have insulins. Insulins we will discuss at a later point. Can we have the next slide? Just try to stop me at any point of time if I'm not clear or if the information is too much. Okay, so these are the various mechanisms of action which we have discussed already. So I don't want to discuss about this slide. Next slide. Same thing, you can see the biguanide.
Can I have a question here? Since you said
yes,
you can.
ma'am.
See, this SGLT2, you said no. If a patient who is on SGLT2 and if he is having dehydration, if they have to give the ORS, is that possible to give or not to give?
Actually, it's a good question. Let us say patient having diabetes suddenly develop loose stools. Let us think like that. Patient is having dehydration. One first thing which we need to do is we should not give these drugs. If the patient is already taking these drugs, we should give a drug holiday. We should stop this drug. Point number 2, you can safely give ORS in that particular patient. In spite of the patient being on SGLT2 inhibitors, it is safe to give the ORS because the receptors are at different levels. The ORS thing which we have discussed, it is mainly through the SGLT1 that is present on the intestine. These drugs are blocking SGLT2 that is present at the level of kidney.
Okay.
So you can safely give the ORS, nothing will happen.
Even this drug also can be given, or we have to stop?
But usually we have to stop this drug because of the fear of dehydration. And once the things settle and once the dehydration is corrected, we can again restart these drugs.
Okay.
One question. So, but SGLT2 is also there in intestine also, no? For the glucose export?
Yes.
But this won't affect that?
But no. These they are completely different. That is SGLT2 1. This is SGLT2
Okay.
So this particular drug is blocking only SGLT2, not 1.
Okay. Kidney.
So that is the reason the intestine thing is not getting affected.
Okay, sure. Thank you, sir.
Okay. So you can look at this slide as well. So various organs have been depicted: liver, pancreas, intestine, skeletal muscle, adipose tissue. So biguanides and triazolidinones act at the site of liver, and GLP-1, DPP-4, and insulin secretagogues like sulfonylurea will act at the site of liver, and thiazolidinones and biguanides again act at the site of muscle and adipose tissue. Finally, alpha glucosidase inhibitors act at the level of intestine. They should have mentioned a kidney picture where SGLT2 inhibitors are also acting. Next slide. So this is a very important slide. These are the various HbA1c lowering capabilities of each and every drug. If you look at biguanide, that is metformin, and if you look at the insulin secretagogues, that is sulfonylureas, they are the most robust oral agents which we have. They bring down the HbA1c by 1 to 2%. And remaining drugs also are good, but mainly metformin and sulfonylureas bring down these HbA1c levels by 1 to 2%. Next slide. So again, biguanides, metformin usually be given after the meals, and you can start with 250 mg or 500 mg either once in a day or twice in a day. If the patient is able to tolerate, literally speaking, 9 out of 10 patients will have a GI side effect within the initial 10 to 15 days. You should clearly tell them. After that, the side effects will come down. Why do they have this GI side effect? Because there is a calcium receptor in the intestine. The metformin is going to block that receptor. And the gut flora, we have good bacteria inside our body as well. Metformin is going to disturb this gut flora. That is the reason initially over the 10 to 15 days, when you start treatment with metformin, that going to have the gastric disturbance. And metformin is also known to cause B12 deficiency in few patients. If you come across a non-vegetarian, I'm again telling you, a non-vegetarian on metformin and diabetes being under control, and the person is not taking any alcohol, and if the person is having numbness or tingling sensation of the feet, it is always better to get a B12 tested. And if you come across a pure vegetarian, whether the patient is taking metformin or not, whether the patient is having diabetes or not, always they will have B12 deficiency, many of them, so better to get a B12 done. So after prolonged therapy of metformin, few patients will get B12 deficiency. And you can go upon the dose of metformin up to 2,500 milligrams per day, provided the patient is tolerating. Liver disease is a contraindication. And if the patient is continuously taking alcohol, you should stop this drug for a few days. And when the creat level is more than 1.5 and when the eGFR is less than 30, we usually don't start this drug or don't continue this drug. And adverse effects we have already discussed. Next slide. Sulfonylureas, the next common drugs that are being prescribed in India. So we have various drugs like glimepiride, gliclazide, glibenclamide, glipizide. Glibenclamide was one of the favorite molecules in 1980s and 90s. No longer many of the doctors are now using this glibenclamide because it's a very long-acting drug, even though it is very cheap. We have the latest sulfonylureas like gliclazide and glimepiride. They are usually given before the meal. They can be given safely. usually they will cause weight gain and hypoglycemia. So when a particular person is taking sulfonylurea, you should always discuss regarding the aspect of hypoglycemia, how to deal with hypoglycemia, what are the symptoms of hypoglycemia, and how to prevent hypoglycemia. And many of these drugs are not given during pregnancy. And chronic kidney disease, when the creatinine level is going beyond 1.8, many of these drugs are not given. So coming to the chronic kidney disease, one important point which you should understand, none of these drugs are going to cause a damage to the kidney if the creatinine is 1.8 or 2 or 2.5 or 3. Basic thumb rule is that, like the way we have a Swiggy delivery boy who is supplying you food and going back, these drugs have a vehicle. These drugs are so much sensitive to hydrochloric acid that is present in the stomach. Many of those drugs have a coating outside. So the coating is like a Swiggy vehicle delivery boy. That coating will deliver the drug, and in the stomach, the drug is being split into the original molecule and the coating. So the original molecule is the one which is going to bring down the sugar. We have got nothing to do with the coating. And many of these coatings are being excreted through the kidney and few through the liver. So what happens in chronic kidney disease when the particular creatinine or EGF, creatinine is going up or EGFR is coming down, the kidney is not able to excrete this particular coating. So these coating or unnecessary things are getting accumulated in the body, and the side effects are because of these things, not in 1.5 or 1.8. We usually don't give these drugs. Can we have the next slide? Pioglitazone. Pioglitazone is a little controversial drug. It's actually a very good drug, but it is as good a drug and it has so many side effects as well. That is the reason it is usually not given in each and every person. Ideally, if you come across a lean person with a BMI of 19, 20 or 18 and with uncontrolled diabetes, you can give pioglitazone. It's a very, very good drug. It's a very, very cheap drug in that particular patient. But the problem with pioglitazone, prolonged usage of pioglitazone will increase the body weight. It will cause fluid retention. It can cause osteoporosis in women. And these are the various side effects of the drug. So it is limited only to particular set of patients, and it acts in the same way like metformin. Next slide. Alpha glucosidase inhibitors. So we have discussed that given with meal, with the first bite, they are going to block this alpha glucosidase enzyme. They have similar side effects like metformin, like flatus and birching, bulping, and all those things. They're very, very mild drugs. You cannot expect HbA1c reduction of up to 1% with them. They will just bring down, let us say a patient is having HbA1c of 7.2. Fasting is normal. After the breakfast is normal, and after the dinner is normal. But after the lunch, sugars always shoot up. So because of that, HbA1c is 7.2. Then you can add one alpha glucosidase inhibitor with lunch. So they are just given with a particular meal where the sugars are going up. So they are very mild drugs. One important thing which you have to remember with alpha glucosidase inhibitor, if a person is taking alpha glucosidase inhibitor and by mistake if the person is developing hypoglycemia, the recovery from hypoglycemia becomes difficult because this particular enzyme keeps on blocking the alpha glucosidase inhibitors. In such a case, you should never give sugar for hypoglycemia treatment. You should always give glucose. Why? Because sugar is a polysaccharide. When you give the sugar that is available on the table, when you give a chocolate, when you give a candy, when you give a biscuit, or when you give a fruit juice for the treatment of hypoglycemia, that will never get corrected because the enzyme is still present, the particular drug is still present in the body. It keeps on blocking the enzyme. Instead of that, straight away give plain glucose, either in the form of glucon D, or we have glucose tablets available in the market like hypotams, which will immediately correct the hypoglycemia. Can we have the next slide? Yeah, so these are called the DPP4 inhibitors. DPP4 inhibitors, basically, they are going to block this enzyme DPP4 so that GLP-1 is available for action in the body. We have various classes of drugs like vildagliptin, sitagliptin, saxa, linagliptin. Linagliptin is the only oral drug that can be safely used in any stage of kidney disease. Even when the patient is undergoing dialysis, you can safely give linagliptin. And the other drugs are good. Basically, if the patient is affordable, they're a little bit costlier drugs. Nowadays, they are rapidly replacing sulfonylureas as the second drug of choice. Why? Because they are weight neutral. You will not have neither weight gain or weight loss with them. They will not cause hypoglycemia. Their tolerability and safety is also very, very good, especially in elderly people. They are very, very good drugs. So many of the doctors are willing to prescribe vildagliptin, sitagliptin, or linagliptin as a second drug of choice next to metformin. And now we have the concept of therapeutic inertia. When you come across a person having 7.5 HbA1c, previously we used to start them on metformin, advise them diet and lifestyle. Now straight away you're starting them on a combination of gliptin and metformin, and we're trying to bring down the sugar as early as possible. So they're relatively safe drugs, especially in elderly people. They're again not given in pregnancy, not given in chronic liver disease and chronic kidney disease, exception being linagliptin. Next slide. GLP-1 receptor agonists, basically they're injectable agents. We have exasenatide, liraglutide, we have dulaglutide. Liraglutide is given once daily injection. Dulaglutide is given once weekly injection. They act at various levels of the body and they bring down the HbA1c. So the basic thing with GLP-1 receptor agonists and SGLT2 inhibitors, which we are going to discuss in the next slide, is that weight. What happened initially, way back in 1990s and 1980s, we never had HbA1c as a measuring tool. Many of the patients used to come to the doctor. The doctor used to test for the urine glucose, either with a Benedict's test or something or the other. They used to prescribe the medicines. They used to ask the patient to come after 1 month and they will recheck the weight. If there is a weight gain, it means the sugars have come down. So weight was a parameter which indirectly tells us whether the sugars are under control or not. But the problem is many of these patients having diabetes mellitus are already overweight or obese. And when you start treating them, they'll start gaining more and more weight. It is called KG-A1C paradox. What do you mean by KG-A1C paradox? KG is weight, A1C is HbA1c. It is like a seesaw. HbA1c is at one end, weight is at the other end. So when the weight is going up, HbA1c is going up, weight will come down. When the HbA1c is coming down, weight will go up. So that was the reason many of the scientists and doctors have invented or discovered two different molecules. One is GLP-1 receptor agonist, the other one is SGLT2 inhibitors. These drugs not only bring down the HbA1c, they even bring down the weight. So they are very, very good drugs. So they are going to address various other aspects of diabetes. Next slide. So SGLT2 inhibitors, same thing which we have discussed. They are act at the level of the kidney. They inhibit the reuptake of glucose so that you will have glucose excretion through the kidney. You will have sodium excretion through the kidney. So sugar will come down, weight will come down, BP will come down, and various other things will happen. Next slide. Yeah. So basically what is happening, we are having a new concept by name, cardio-renal vascular axis or continuum. When it comes to type 2 diabetes mellitus itself will cause kidney disease. It itself can cause heart disease, and kidney disease, which is a complication of untreated diabetes mellitus, can result in heart disease. And many of the patients at the time of diagnosis of type 2 diabetes mellitus will have an undiagnosed heart disease and kidney disease. So it is a complex. So we should not only treat diabetes mellitus, we should even take care of the heart of the patient. We should even take care of the kidney of the patient. So when you give a particular drug, if the drug is able to bring down the sugar, if the drug is able to take care of the kidney, if the drug is able to take care of the heart, it is a blessing for us. So SGLT2 inhibitors and GLP-1 receptor agonists are the only class of drugs which not only bring down the HbA1c, they are also going to protect the heart and the kidney. Now, the recent guidelines, let it be the American Diabetes Association or any other international guideline, they are quickly changing. After metformin, they're asking all of us to start treating the patients with GLP-1 receptor agonists and SGLT2 inhibitors. Sulfonylureas, thiazolidinediones are pushed back. But the problem with Indian market or Indian patients is cost. Many of these patients belong to middle class and lower middle class. These molecules, GLP-1 receptor agonists or SGLT2 inhibitors, are very costly. So even today in India, 90% of the patients are still taking sulfonylureas as the second line of treatment after metformin. That is one important aspect. So when you come across a patient, start the treatment, give the diet counseling, give the lifestyle modification. There is no wait and watch policy. They should bring down the sugars as early as possible. HbA1c should come down to 7 or less than 7 in 3 months. If the HbA1c is not settling, if the fasting or post-meal values are not coming under control, you should start intensifying the treatment. Either increase the dose of metformin, increase the dose of DPP-4, or increase the dose of sulfonylurea, or add one more drug. So there is no wait and watch policy in the treatment of diabetes mellitus. That's what intensification means. And the patient should check his or her blood glucose in the home, either with a glucometer or any other device that is available in the market. They should come back to us either once in a week, once in 2 weeks, or once in 3 weeks, so that we can look at the values and we can modify the treatment accordingly. Next slide. So these are the various brands that are available. So we should not discuss regarding the brands. Next slide. So what are the other aspects of medical management apart from diabetes? So like rightly pointed out, the person will be having uncontrolled blood pressure. There are various other comorbidities like hypertension, like dyslipidemia, like hypothyroidism, like kidney disease, like heart disease. So it becomes imperative on our part to take care of all these aspects. I'm just treating diabetes. I'm least bothered about your blood pressure. I'm least bothered about your cholesterol. We cannot say like this. We basically are medical professionals. So it is our responsibility to address the various other aspects of diabetes management. Next slide. So when you come across a person having diabetes mellitus, it is always better to check the blood pressure value, either the home-based or office-based value. Check the blood pressure. If it is around 120 by 80, and if it is more than 120 by 80, advise a lifestyle modification, cut down the salt intake. Salt in the sense, there are 3 sources of salt in the food. One is the regular food, regular meals. Second is salted chips, salted nuts. Third is pickle. We should ask the patients to avoid the pickle and salted nuts and salted papad or something, but the regular salt in the food should be consumed because salt is even essential for life. Second, if the BP is more than 140 by 90, they should continue the lifestyle modifications in the form of exercise, diet, and all those things. And they should start giving, we should start them on antihypertensive agents. And lastly, when the BP is more than 160 by 100, you should add one more antihypertensive agent. So we have various drugs available for the treatment of blood pressure. Let it be angiotensin receptor, receptor blocker, ACE, calcium channel blockers, diuretics. This discussion is beyond our scope, but I just want to mention that hypertension needs to be treated as well. Next slide. The same way, dyslipidemia. You should always measure the LDL cholesterol, HDL cholesterol, and triglycerides. LDL more than 100 needs to be treated. That is a bad cholesterol. And HDL should always be more than 40 for men and 50 for women. And the same way, triglycerides are most labile cholesterol. When the sugars are high, suddenly the triglycerides can go up. Any value of triglyceride up to 500, you need not treat, because when you start treating diabetes, triglycerides will automatically come down. But if the value is more than 500, we should start treatment with a drug called fenofibrate so that the pancreas are not getting affected. So we have various ages. According to the age and according to the presence of risk factor or heart disease, we should decide whether to start the treatment with statins. Statins are the new age aspirins. Previously, 1980s and 90s, left and right, we used to give aspirin to each and every person having diabetes. Nowadays, we are not giving aspirin. We're trying to give statins. The first question which the patient asks, my LDL cholesterol is 124. I don't want to take statins. I will bring down with the help of diet. So then you can calculate the risk factors. You can show this particular slide to the patient. Look, your age is 42. You're already smoking. You consume alcohol. Your waist circumference is high, and you have diabetes. You have 3 risk factors for the development of heart disease. So it is better to take statin. That's how you have to convince the patient. Next slide. To summarize our discussion, always remember there are various good drugs available for the treatment of diabetes mellitus. Second, there is no wait and watch policy. You should be very much aggressive when it comes to the treatment of diabetes mellitus. You have to bring down the sugars as early as possible. Better to start 2 different drugs with HbA1c is around 7.5. And when the HbA1c is not coming under control in spite of aggressive therapy, you should keep on adding drugs. And many of the drugs you should have a sound knowledge regarding the mechanism of their action as well as side effects. And all these drugs are relatively safe. You can clearly tell the patient nothing is going to happen to your kidney in spite of using these drugs for 20 years, 30 years. And lastly, the treatment options are rapidly changing throughout the world. We are even taking the heart disease and kidney disease into consideration. There are few drugs, in spite of being costly, they are given as a second line of agents because they bring down the diabetes and they take care of the heart and kidney. And apart from diabetes, we should take care of the blood pressure and the lipid management and various other comorbidities like hypothyroidism. Next slide. So we'll quickly finish the insulin therapy. Actually, it is a very, very interesting topic. Because of the paucity of time, we cannot discuss in detail. Next slide. Next slide. So when do we start insulin in type 2 diabetes mellitus? Let us say the patient is taking 4 or more than 3 different drugs or more than 4 different drugs. In spite of that, the HbA1c is not coming down. In spite of that, the fasting and post-meal values are not coming down. Then we start insulin on that particular patient. Second, a newly diagnosed type 2 diabetes mellitus patient with very high HbA1c value, more than 9, 9.5, 10%, we usually give a short course insulin therapy. Third, the patient needs to get admitted into a hospital, maybe for a tooth removal or for a surgery or for a cardiac issue. Then we start the insulin. Fourth, any case of acute emergency like COVID-19, patient is having diabetes, is on oral drugs, sugars are under control, the patient got COVID-19 infection, he or she needs to be admitted in the hospital, insulin remains the main therapy. Accidents and all these medical and surgical emergencies or elective surgical conditions, insulin is given. Apart from these, type 1 insulin always remains the only treatment of choice. Pregnancy, insulin is the treatment of choice. Pancreatic diabetes, insulin is the treatment of choice. Secondary diabetes, when the patient is given steroids for 5 days or 6 days or a month, insulin remains the treatment of choice. And lastly, there can be few conditions like the patient may be having a wound ulcer. HbA1c might be only 7.5 or 8, but we don't have time. The sugar should come down immediately so that the ulcer heals, or else the patient, we need to amputate the foot. Then you can give a short course of insulin therapy. So these are the various indications for insulin therapy. When it comes to type 2 diabetes mellitus, you should always remember insulin is not a long-term treatment. Until unless the patient started having diabetes for 20 years, he or she took 4 different drugs, even then the sugars are not coming down, then insulin might become a long-term treatment. But initially, when the sugars are very high, patient came to you for the first time, we give a short course insulin therapy because it is a condition called glucotoxicity, where the pancreas has literally been shut down. There is no insulin production. Even when you give metformin, even when you give sulfonylurea, even when you give thiazolidinedione, sugars will never come down. So when you give insulin for 5 to 10 days, the insulin that is being administered from outside will bring down the sugars. The pancreas will recover. It will start producing insulin on its own. Triglycerides will come down. All these good things will happen. So you should convince the patient to take the insulin for 5 to 10 days. And you should tell them clearly. Many of them ask, my uncle has been taking insulin for the past 20 years. Once you start insulin, you cannot stop. Nothing like that. We can stop. Should counsel them for the insulin initiation. Next slide. Next slide. Can we go to the next slide? Basically, why did I skip those 2 slides? The information is clearly given in this slide. You can classify insulins in different ways. The first step of classification, depending on their duration of action. Either you have short-acting insulin or long-acting insulin. And like the regular, then first classification you should remember is short-acting and long-acting. Then you have ultra-short-acting, intermediate-acting, ultra-long-acting. Go back to the previous slide. Previous slide. So these are the conventional insulins or regular insulins. Conventional or a regular insulin is exactly the same as the insulin available in the human body. Right from 1925, when insulin was discovered by Banting and Best, right from that point of time, we started identifying, we started to isolate, and we started to produce insulin. Initially, we used to give insulin from pigs, from cows, from sperm fish and various other animals. In 1980s and 1970s, we started producing insulin from human pancreas, and we used to give this insulin to other patients. So these are called the conventional insulins or regular insulins, which exactly resemble the insulin present inside the human pancreas. The same insulin we're giving in a cartridge or a bottle. Next slide. So what do you mean by analogs? They are different from the conventional insulins. So the insulin is tweaked in such a way that, let us say, the conventional insulin is acting for 2 hours. This particular insulin will act for 3 hours. The conventional insulin is taking almost 30 minutes to act. This particular analog will take 10 minutes to act. That is for the short acting. In the same way, long acting, the conventional insulin was acting for 12 hours. These analogs are acting for 16 hours, 24 hours, 36, 38 hours. So the basic differences, first classification, we classified them as ultra short acting, intermediate acting, long acting, and ultra long acting. And the second is conventional regular insulin, which resembles the human insulin. And second is the analogs. This is the second type of classification. If we combine them together, the classification is different again. Regular insulins are either short acting, intermediate acting, or long acting. Analogs are either ultra short acting, long acting, or ultra long acting. So I just don't want to confuse you people. This is how the insulins are classified. Can we have the next slide? Yes. Next slide. Apart from that, there is one more classification. So you have a short acting insulin, you have a long acting insulin. So how is insulin produced in the body? Insulin has a pulsatile pattern. It is produced with each and every meal. So we have a basal bolus insulin secretion in the body. What do you mean by basal? Whether you have food or not, insulin is produced throughout the day, 24 hours. That is called the basal insulin. It has got nothing to do with your food. This is the one which will keep the liver under check. It will make sure liver is not producing extra glucose. Then whenever you have food, let it be your major meal or let it be your snack, then body starts producing small boluses of insulin. That is how insulin is produced in the body. So bolus is short acting, basal is long acting. So when you combine, when you start insulin treatment for a type 2 diabetes mellitus patient, that let us say the patient has been taking 4 different drugs for 20 years, sugars are not under control. Patient recently came to know that he is having diabetes, HbA1c is very high, you want to give insulin. Then we start with the basal insulin. That is the long-acting insulin. And again, the long-acting, either we can give a conventional insulin or we can give an analog. That is how the basal insulin are given. Then the second type of insulin, let us say you have given basal insulin. Patient is having diabetes for 20 years, 4 drugs, sugars are not under control, HbA1c is 8.6. You started the basal insulin. Good, HbA1c came down to 7.5. But the target is 7. Fasting is under control. But after the breakfast, sugars are still high. After the lunch, sugars are still high. Then you can start giving insulin 2 times. That is called pre-mixed, where you're combining the short acting and long acting together and giving as a single shot. Either like 30 by 70, 50 by 50, or 25 by 75. It is called pre-mix. These are the various regimens of insulin. So in a premix regimen of insulin, you are combining a short acting and you're combining a long acting and given. You can combine a conventional or regular insulin as a short acting, and you can combine this with an analog. Or else you can combine an analog to one more analog. When you combine 2 different analogs, it's called co-formulation. Leave about it's confusing. So first regimen is basal, second regimen is premix. Then we have the third regimen where we need to exactly mimic the body. That is called basal bolus, where you give 3 different shots of insulin with each meal and 1 insulin as basal before going to bed. So in type 2 diabetes mellitus, you can give either a basal or you can give premix or you can give basal bolus. So sequentially start with basal, sugars not coming down. Switch to premix, sugars are not coming down. Then you switch to basal bolus. Apart from type 2, in hospital setting and in type 1 patients and in pancreatic diabetes patient, in pregnancy, usually we'll give basal bolus. We don't give basal alone or we don't give premixed. Clear? And can you go back to the previous slide? Previous slide? Yeah, you can see these are the various insulins that are available in the market. Insulin is either is available as a cartridge or as a pen. The difference between cartridge and pen, you can see the first picture. You have seen a cartridge there and a bottle as well. The vial or the bottle has 10 ml of insulin. Each ml has 40 units of insulin. Whereas the cartridge has 3 ml of insulin. Each ml has 100 units of insulin. So in a cartridge, there is more insulin when compared to vial. Let us say the patient requires 40 units of insulin. You need to take 1 ml through the vial and 0.25 ml through cartridge. So through cartridge, ideally speaking, less volume of insulin is going inside the body. Second, vial, it is difficult to store. You should always keep it in the fridge. Very difficult to carry. You should either carry it in ice pack or a flask. Whereas cartridges in a temperature like Bangalore, you can leave them outside. Vials, you need to administer. You can see the third picture with the help of syringe. Whereas cartridges can be administered with pens. They're easy to administer. So to be simple, vials are age old. They're cost effective, and more than 60%, believe or not, more than 60% of Indians who are using insulin are still taking vials. They're not taking cartridges. That is the pity in India. There are cartridges which are as cheap as vials. Even then, many of the doctors are reluctant to start cartridges. Many of the patients are reluctant to start the cartridges. They are still taking vials. We're not against vials, but the medicine is getting advanced. It is becoming more scientific. So it is the right time for all of us to convince the patient, to counsel the patient, and you should change them from vials to cartridges. Next slide. Next slide. So these are the syringes that are used with the vials. Next slide. So there are various factors that need to be taken into consideration while administering insulin. You should teach the patient the right technique and way to administer the insulin. Usually it is given on the abdomen, that is the area with the largest site for absorption, followed by the lateral aspect of thigh. And you should always ask the patient, well, let it be the vial or let it be the cartridge. They should keep on changing the needle at least once in 4 days. They should rub the area of injection before injecting, either with alcohol or normal saline. The moment they inject the insulin, they should count from 1 to 10, then only they should remove, because even 1 drop of insulin left in the needle is equal to 1 unit. And storage is also important. Cartridge should always be, vial should always be stored in the fridge, and it should be carried in an ambient condition. Next slide. Next slide. So many of the patients are reluctant to start insulin. First thing, they fear that when you start insulin, you should continue forever. Second fear is injection, fear of injection. You should clearly tell them these insulins are manufactured in such a way that you can administer the insulin with the help of a 4 needle, a very, very ultra fine needle, relatively painless. You yourself can administer 1 unit of insulin show to the patient. Why? Because these insulins are relatively painless. Many of the type 1 patients, because of our bad luck, are still young. The youngest patient in my life whom I have seen is a 1 week old kid. The 1 week old kid, we had to administer insulin on her. And this particular kid is going to take insulin forever till the age of 80, 90, or 100. So keeping these kids in view, we started manufacturing such a fine needle. This particular needle is completely painless. It is very easy to administer. So pain is not an issue at all. Many of them fear about weight gain. Yes, there can be weight gain, but the newer generation insulins will not cause much weight gain. And when you start doing exercise and when you start modifying your diet, there can be a concomitant weight loss as well. So these are the main factors which many of them fear. And lastly, the cost. Yes, cost might be little on the higher side, but you are spending for your own health. Do you want to live with a value of 500 or 600 sugar? No, it is not the right way. So don't never look at the cost. If you go to coffee day and order 1 cappuccino, what is the cost of that? If you go to a mall and watch a movie, what is the cost of that? You're spending for your own health. So never discuss about cost in case of emergency. Next slide. So this is how you rotate the injection site while giving insulin. Insulin should not never be taken on the same spot. Should keep on rotating the site. Next slide. Next slide. So these are the various steps used in the administration of insulin. I'm going to anyway mail these slides. You can see them. Next slide. Yeah, next slide. So these are the various aspects which you need to consider while giving regular insulin. That should be taken 20 minutes before the meal. While you give an analog, either in the form of a premixed or bolus dose, it should be taken 10 minutes before the meal. Now we have Fias, the latest ultra short acting insulin available in the world, that can even be taken with meal or after meal. And basal insulins are usually taken at the supper time at around 9 p.m. or 10 p.m. before going to bed. And the patient should take the basal insulin at the same time every day. Next slide. And insulin storage we have discussed. Usually the particular vials or cartridges should be stored properly. The vial should be stored in the door of the fridge, not in the deep freezer. And you should take out the insulin, keep it outside for 10 minutes, then you have to administer the insulin, because cold insulin is always painful. And you should carry it either in a flask or an ice pack when you're going outside. Whereas cartridges in a condition like Bangalore can be taken outside without any storage in ice pack or a fridge. But when you go to a place like Chennai or Delhi or Mumbai, where the temperature is very high, you should even store the cartridge in the door of the fridge. Next slide. So these are the various delivery devices, pens. And apart from the insulin, which we have discussed now, we have other insulin delivery devices like pumps and inhaled insulin. Inhaled insulin was a failure, which is not available now. Next slide. Next slide. Next slide. Next slide. Yeah, the pumps are a little bit different. The difference between the pump and regular insulin: in pump we are using a short acting insulin which continuously produces insulin throughout the day. Pumps are ideally suited for young type 1 patients who don't want to take multiple doses of insulin, or the parents are not willing to give 4 different types of insulin, 4 different shots of insulin in a single day, or type 2 patients who have enough money and who don't want to take multiple shots of injection. You can start them on a pump. The advantage with insulin pump: first thing, it is pain free, no need to take an injection from outside. It is completely supplying the insulin throughout the day, and the latest pumps have artificial intelligence in them. I'm talking about the pumps available in India. What is happening here? And you can see the first picture. The right hand side of the panel, you can see a small black colored device like a mobile, which is the pump, which is inserted with the help of a tube onto the abdomen. That is the one which is delivering the insulin continuously. You can feed various bolus and basal patterns, and accordingly the insulin is delivered. The left hand side, there is a small patch. It is called CGMS, continuous glucose monitoring system or device. So this entire setup is called Guardian Connect. So what do you mean by Guardian Connect? This is attached to, let us say, a 10-year-old kid going to the school. Pump is fixed, Guardian Connect is fixed. The particular kid is sitting in the class at around 11 o'clock. Suddenly the sugar is shooting up to 250 or 300. Immediately the father, the mother, the treating doctor will get messages on their mobile stating that the kid's sugar is going up to 200 or 300. Immediately they will call up the teacher or the school authority, and the particular kid can immediately take some 4 units or 5 units of insulin as a correction dose. Same thing with low sugar. Suddenly the kid's sugar is dropping to some 90. Immediately the parents sitting in the office will get an alert. So they can immediately tell the teacher to suspend the pump. Not only that, all these pumps have an auto suspension capability. The sugar touching 100, the pump suspends by itself. And not only that, they have programs inside. They can predict what is going to happen in the future. The patient had 8:30 breakfast, 9:30 suddenly the sugar became 150, which should not have happened. So that particular pump will tell the patient, I think your sugar is going to become 300 by 10:30, so better to take some extra insulin now. The patient did not listen to the pump. Again 11 o'clock he will get an alert, the sugar has become 250, please take an extra correction dose. The patient did not listen. By 11:30 the sugar will become 350, he will get an alert, he will get a beep, and the pump will keep on telling the patient, please take, please take. So it has an artificial intelligence inside. And the pumps that are available in the US have glucagon inside. It is a closed loop. The glucagon will take care of the hypoglycemia. And we should not worry about the cost. Yes, they are costly devices. Their cost is around 1.5, 2.5 or 4 lakhs. But many of these pumps are available over finance schemes. If you come across a type 1 patient, young patient, whom you can't see the patient is suffering, the particular kid cannot take insulin 4 times. The parents don't know how to administer. You can advise them to go for a pump. Why? Because they can pay a down payment of 10,000, 20,000, and they can avail the finance scheme. And these companies are giving the pumps for finance. So they're going to have a good quality of life. So pumps are also very, very helpful. Not only type 1, you can even give them in pregnant women. You can even give them in elderly type 2 patients. Next slide. So these are the various types of pumps available in India. Next slide. Next slide. Next slide. So inhaled insulin, it was famously called Efraza. It is not available in India. It was a failure. Now they're trying to manufacture oral insulin, which is under various stages of development. It will take some more time for us to see whether we can really have oral insulin or not. Next slide. So to summarize the discussion, insulin usually is given in type 2 diabetes mellitus patients when they have sequential drug failure, when they're admitted in hospital, when they have some acute life emergency, and when they're undergoing some surgery. In the same way, type 1 diabetes mellitus, insulin remains the mainstay of treatment. Pregnancy, pancreatic diabetes, insulin remains the mainstay of treatment. We have various types of insulin like short-acting, long-acting, ultra-short-acting, intermediate-acting, ultra-long-acting. The same way we have conventional regular insulin, we have analogs. And you can combine these various insulins and develop regimens. You can have a basal insulin, you can have a pre-mixed regimen, you can have a basal bolus. And we have to follow the various steps in the administration of insulin. We should even counsel the patient regarding the storage of insulin, maintenance of cold chain. And you should counsel the patient. You should alleviate the fear the patient is having regarding the insulin intake. Let it be the pain, let it be the hypoglycemia, let it be the long-term usage. Next slide. I think there are a few more slides regarding the dietary considerations, and the time is also, we have overshoot. I would request you to share the slides with the students so that they know about these dietary considerations. Let it be the carbohydrate counting or exchange or all those things, which is not prudent on our part to discuss now. They can go through the slides, and if you have any doubts, you can get back to me. So I would like to stop here. So any questions?
Even they can go through, and tomorrow also they can ask some questions.
Sure, definitely.
So questions you can post in chat box, students. Lakshmi, you can close this. Anything to ask with this slide?
Dietary consideration. Shall I scroll the slide once, or we will just send it to them?
You send it to them. I think there are around 30 slides in that. And someone was asking, Shefali, is intermittent fasting beneficial for diabetes control? Intermittent fasting is beneficial in a person not having diabetes. But in a person having diabetes, we don't have enough evidence to support intermittent fasting. We usually don't advise. But when you come across an overweight or obese person who is at risk for developing diabetes, you can advise definitely the intermittent fasting, which is rapidly catching up with the world, along with the keto diet, so that they can start losing weight and the risk for developing diabetes can be reversed.
Doctor, I have a question.
Yes, ma'am.
Suppose you are on AC inhibitors or ARB, even then we should have an aggressive diet restriction on salt?
That's what, ma'am. Salt actually is like a paradox for us. Salt restriction is only through the chips and these particular pickles and papads and all those things. We never ask them to cut down on the salt intake with their regular food until and unless they have a chronic kidney disease where salt intake is reduced. Even though there are antihypertensive agents like AC inhibitors or ARBs or diuretics or calcium channel blockers, we advise them to cut down on the salt, because at the end of the day, if the dietary restriction is able to help them, we can actually cut down on the oral medicines as well.
Okay.
Diet always plays an important role.
Tomorrow I will ask them.
Some institutes say that they can reverse diabetes through diet only. How far it is true, It is actually not that much true. There are few programs available even in Bangalore, like the Twin Diabetes program. Dr. Pramod, someone is there in Mumbai, who keeps on promoting himself that he can reverse diabetes through with diet. Diabetes can never be reversed with diet. You should always remember. There is actually no reversal of diabetes. The last session also I have shown you one case I've discussed. Her HbA1c is still at 6.2, 6.8. She did not become a normal person. For a normal person, HbA1c should be less than 5.6. Only good thing which happened in her case is she was able to cut down all the medicines over the past 18 months. So we are able to control diabetes without medications, with the diet and with the lifestyle, but we were not able to reverse the diabetes till now. So it is not a proven concept. We should never go by that. And they're costlier as well, all these programs.
So I have a question, doctor. This is actually pre-diabetic, that is 5.5 to 6.5. Should they take drug, or
Yes, ma'am.
only lifestyle and diet is enough for them to,
It depends on the person. Today I've seen one ticket collector who brought his mother. Mother is my patient. So this ticket collector is 40-year-old. HbA1c is 6.5 for the past 3 years. So ticket collector, you can imagine his lifestyle. He will have his lunch whenever he wants. There is no particular time. He's having stress. He's the only earning member in the family. He's having 3 sisters who need to get married, all those things. So these type of patients require treatment. I've started him on glycomet, that is metformin 250 mg BD, till the HbA1c is coming down to less than 5.6. But when you see a highly motivated person who can do diet and who can do exercise, obviously there is no need of any medication in them.
and here the age also matters, no?
Age also matters. When you see an young patient with 6.5, I mean, it's a tricky question actually. When you see an young patient with 6.5, we actually panic.
Yes.
The doctors panic, not the patient. Because why at the age of 25 only this particular fellow got a 6.5 HbA1c. But even then, young patients, usually we start them with diet and lifestyle, and middle-aged we should start them with oral medications.
Okay.
Even the pre-diabetes stage.
And one more question. They say that usually that the risk factors or the prone to diabetic is between the age of 45 and 55 or 60 years. After that, it is reduced. Is it so?
No, ma'am, it is rapidly changing the concept. There is no particular age where you are more prone to develop diabetes. Because of the increased prevalence of childhood obesity in India, because thanks to the various schools and curriculums where they don't have any play, only education, many of the young people are having diabetes, 25, 30, 35. The same thing, even though you're 65, even though you're 70, till date you not get diabetes. It doesn't mean you're immune. You will never get diabetes in your life. We have seen a 75-year-old lady in CMC Vellore who got LADA, who got type 1 diabetes at the age of 75. Can you imagine?
Okay.
It is never safe. It is not like a particular age is safe. You will not get diabetes. A particular age you will get diabetes. Any age you can get diabetes, but usually it is seen in middle-aged population. But as age progresses, better to be under control. They should always get their test done. Let us say 65, 70, 75. Problem with that age, let us say they developed diabetes at the age of 75. Till then, they never had. They were more relaxed. Their kidneys, their lungs, their heart, they will be in a very, very sensitive phase at the age of 75. Even a little bit increase in blood sugar can affect any of these organs. So 70 years or more than 60 is actually a very sensitive age group.
Okay. We have some questions.
Some question in the chat box.
I have a question. Is it a myth saying, say, for example, if father is diabetic, the daughter is more prone to have, the chance of diabetes is more, something like that? If
You
mother,
mean to say father and daughter, mother and son, or original
yes,
parents?
no, father and daughter, mother and son.
No. Father shares more love to daughter and mother shares more love to son, but they never share diabetes. Don't worry.
Okay.
It is not like father and mother. If one of the parents are having diabetes, irrespective of gender, the child there is a chance 25% of the child getting diabetes in adulthood. The same way, if both the parents are having diabetes, there is a 50% increased chance of getting diabetes in the adulthood.
Okay.
What
And
about grandparents having, parents not having, and the grandchildren? Will they be prone, or how it is? It's the chance. What is the percentage
if
of
the
chance?
grandparents are having and the parents are not having, it depends on the other family members. We need to have a detailed family history. Grandparents, their siblings, their children, parents, their siblings, their cousins, so that there is a chance of Modi in the family. If there is Modi, sometimes Modi can skip one generation. Parents may not have developed Modi, or the Modi gene became silent in the father or mother, and the child can get affected. But only the grandparents are having, parents are not having, and other family members are sporadically having, then you can be safe. The children may not be getting diabetes, but whatever said and done, irrespective of family history, in India, more than 30, you are prone to develop diabetes.
There are questions in the chat.
Yeah, what is the best diet to manage diabetes? Nikita Walton, the best diet is, that's what you should tell, not me. So best diet is actually, it's like a pyramid, like the Egyptian pyramid. The base of the pyramid is the breakfast, the middle part of the pyramid is the lunch, the tip of the pyramid is the dinner. So if you go from bottom to top, we're increasing the quality, we're decreasing the quantity. You should ask the patient to have a carbohydrate diet in the morning, a fat-rich diet in the afternoon, and protein-enriched diet in the night. Coming to fruits, they can have each and every fruit except the fruits which are rich in glycemic index and low. And fruit should be taken in the morning between the breakfast and lunch. Nuts which have fiber should be taken in the night. And milk and dietary supplements. Basically, thumb rule is your diet should look colorful. Greens, fibers, fruits, and all those things should be included. Avoid on coconut, sweet, jaggery. Can the pen and vial both be used in certain disease conditions or when a person is admitted in the hospital? Yes, definitely. We can either use the pen and vial, both have their own advantages, but basically, pen has more advantages when compared to vial, when it comes to the storage and when it comes to the ease of administration. Do diabetic drugs affect the kidney more than the diabetes itself? No, not at all. Not only diabetic drugs, there are only very, very few drugs in the world, like an antibiotic, like aminoglycoside, like few painkillers which are going to affect the kidney. These drugs are limited. They're given only when recommended, when needed. But many of the drugs, liver diabetes, thyroid, blood pressure, heart disease, none of these drugs are going to affect the kidney. You can be related, very much be assured and safe. You said ORS is good for dehydration, but since ORS contains sugar, yes, it's a good question. In diabetes, more than sugar, when the person is having dehydration, we are worried about the fluid loss and the salt loss. So at that point of time, the life is endangered because of the fluid, because of the dehydration. So immediately you should rehydrate the person, even at the expense of increased blood sugar. You should not worry about increased sugar. They should take the ORS. With every loose stool, with every vomiting, they should take 200 ml. Nowadays, we're getting tetra packs of ORS ready-made. Previously, we used to mix the ORS in a 2-liter water we used to consume. Now that junjet is not there. We can directly consume that ORS tetra pack 200 ml. With each loose stool, each vomiting, they should have one ORS. Sir, you said a pre-diabetic can be prescribed the keto diet. No, 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 I did not say the pre-diabetic can be. I'm talking about a normal person. A normal person who is at risk for developing diabetes. Risk for developing diabetes in the sense he might be overweight, he might be obese, he might be a software engineer, he might be a doctor, he might not be having a proper lifestyle, proper diet. So if they want to lose their weight, you can prescribe keto diet. But pre-diabetes, never we prescribe keto diet. However, improper, unregulated keto diet makes more one. Yes, 100% true. Recently, a celebrity from West Bengal or somewhere, she succumbed to keto diet. Keto diet is again controversial. There is a big scale research going in US. Anytime we are going to publish the data that is going to give us guidelines regarding keto diet. Keto diet should always be short term and should always be monitored by a professional like a qualified dietitian or a qualified doctor. Basically, keto diet is fat enriched diet. Then product of fat metabolism are ketone bodies. If you don't regulate this diet, ketone bodies will go up in the body and they're weak acids. Acid builds up the body and they'll start developing these problems like chronic kidney disease and heart disease. So short term, for a few weeks like that, keto diet is always beneficial for weight loss in a person not having any problem, not even hypertension, not even dyslipidemia, not even diabetes. How do you manage the insulin for a patient with tuberculosis and liver cirrhosis? Insulin is the only drug available for tuberculosis and liver cirrhosis. The same thing I told you in the previous discussion. In liver cirrhosis and tuberculosis, the targets for blood sugar are relaxed. We are not that much stringent. We give a target of fasting of 100 to 140 and post meal 140 to 200 to prevent hypoglycemia. When you have a combination of liver cirrhosis or chronic kidney disease, they should never have hypoglycemia. Are the sugar alternatives like stevia recommended? How safe are they? They are safe. There is in the slides which I'm going to mail you, we have a slide on the artificial sweeteners like S-sulfame, aspartame, or stevia, whatever it might be. We have various artificial sweeteners like heat labile, stable. Whatever said and done, they can be used as an alternative to sugar in limited quantity. I have a patient who uses that 100 sugar-free tablets and he will prepare pongal, sweet pongal, and he will consume. That should never be the thing. Once in a while, if you want to have a sweet coffee or a sweet pongal or a sweet payasam during an occasion, they can have the stevia or any other artificial sweetener. And on a regular basis, in a limited quantity with 1 cup of tea or 1 cup of coffee, they can use.
So I have a question. In
Yes.
GDM cases, you cannot control with drugs.
No, ma'am. None of the drugs are approved for GDM. Only metformin has been studied in Australia. There was metformin in gestation, MIG study, and the Australian scientists have clearly showed the benefit of metformin, but none of the governing bodies have advised, let it be the Gynecological Association, Diabetic Association, they haven't endorsed the treatment of GDM with metformin, but off-label we use metformin because metformin has its own benefits in pregnancy as well. But apart from metformin, none of the oral drugs can be given in GDM. The only treatment in GDM is insulin, that too 4 times.
Okay,
the problem,
thank you, sir.
1 day in pregnancy is equal to 1 year outside. So it is a very, very precious state.
Sir, is it a patch is used for the treatment patch?
Treatment patch is also controversial. Few patches are available in the market. They are not approved. Only thing which is something like patch is the insulin pump. Apart from that, there are few patches. They say the insulin is released gradually and all those things. We do have insulin leaf in India.
Okay.
Many of the patients come back and show this insulin leaf I have taken 3 times of sugars and control. So all those things are not approved. They are like diabetes is a big time market everywhere.
Okay.
Every diabetes, they keep on doing all these things. So these patches as of now are not advisable.
Okay.
Why is diabetes so important for COVID disease? Tomorrow we are going to discuss the Shefali. I keep on hearing this Shefali's name with every batch.
Yes, she has a lot of things to ask. After class she was messaging me.
Every batch in the sense, yeah, all the sessions she has been asking. NDP, there were 2 batches of students from Mount Carmel. Invariably, there was one or other Shefali in every batch. Can someone without diabetes and not in the borderline of diabetes replace sugar with sugar alternatives? Yes, they can do that. Definitely. Any other questions?
So if they have questions, they can reserve the questions for tomorrow's session. Okay.
Sure.
Already we are very close to 6. So we will close the day. And it was really a very good eye-opener for many of the students, I think, to know about the drugs and how they act on the different organs of the body. So that one slide is a very, very good slide, how these drugs, because we all know about the dietary part and the lifestyle part, how we have to. But these drugs, what you have simplified and explained us, definitely it will be there, like, installed in the memory. Thank you, Doctor.
Thank you. Thank you very much. Thank you.
Thank you, sir.
So we'll break for a coffee. Thank you.
Thank you.
Thanks a lot.
Usually we used to have a coffee there when we are having the classes. Now virtual coffee we will all have. Okay, thank you very much.
Take care.
Thank you all. Tomorrow we will all meet.
Same time, no, ma'am? Tomorrow?
Same time, sir. 4:30.
Same time.
Thank you, sir. Thanks, everyone.
Take care.